Hello everyone and welcome to this week's episode. We are delighted to welcome to The Nutshell two guests, Dr. Gavi and Maya Eylon.
Dr. Gavi is a Harvard-trained medical doctor who works at Stanford Hospital and Stanford Medical School in California, and Maya Eylon is a medical researcher and medical student.
And they co-authored the brilliant book, Preventing Prostate Cancer, Reduce Your Risk with Simple Proactive Choices. And this is a book which we feel should be read by everyone, not just by healthcare professionals, but everyone who has a prostate, and perhaps everyone who knows someone who has a prostate. So I think that's absolutely everyone, isn't it, Daisy?
Definitely. Who wouldn't want to know how to reduce their risk of developing prostate cancer with simple lifestyle changes? So thank you so much, Dr. Gavi and Maya, for coming on the podcast today.
Thank you for having us.
Thank you. It's our pleasure to be in conversation with you.
Brilliant. Thank you. So most of our listeners would have heard about lifestyle changes they can make to reduce the risk of common conditions like cardiovascular disease or type 2 diabetes. But I'm not sure how many of us are familiar with how much of an impact lifestyle can have on our risk of developing certain cancers. And as Claire mentioned, you both authored the book, Preventing Prostate Cancer. So we can't wait to hear more about these lifestyle choices. But before we do, can you set the scene and tell listeners a bit about the brief facts of the prostate gland, what it is, what its function is, and how it can cause men symptoms or problems?
Sure. Well, let me respond to two things you said. One is about many people not being aware about the importance of lifestyle factors on prostate cancer. I would say that many doctors aren't aware about the importance of lifestyle factors. And I was not aware as a Harvard-trained doctor, probably until about 15 years in practice, about the role of lifestyle factors in prostate cancer. And when I stumbled across this data, I was really blown away. And I'm a practicing doctor. I'm not a medical writer, but I felt compelled to get the message out. And so it's been an educational journey for me as well. In response to what is the prostate gland and what kinds of issues it can cause for men, is the prostate gland is a gland that lives at the base of the bladder. The urethra passes through the prostate, and it makes important secretions that facilitate healthy genital function around secretions for semen and healthy function. And it supports the function of reproductive health for men for years and years. However, as men get into their 40s and 50s, not all men, but many men, the prostate begins to enlarge because of the influence of testosterone and byproducts of testosterone. And so it can cause issues. The most common issue is enlargement, and enlargement of the prostate can begin to impair bladder function. And then the second issue, which we're talking about today, is prostate cancer, which affects approximately 1 out of 8 men during their lifetime.
Yeah, and I think that's interesting, isn't it? Because we all hear about the prostate enlarging as men get older. And I've always thought that's strange because everything else seems to shrink or atrophy. Do we know why that is? You mentioned testosterone, but I thought testosterone also decreases as men get older.
Testosterone does decrease, but it's a gradual decrease. It happens very slowly over time. Unlike estrogen levels, which really decrease around menopause, testosterone levels decrease much more slowly, maybe 2, 3, 4% per year. And so it's a more gradual decrease.
And as men get older, their bodies produce more dihydrotestosterone, which is a byproduct of testosterone hormone. So they produce more of that. And that hormone has specifically been implicated in prostate enlargement. It has been shown to directly increase the proliferation of prostate cells, which is one theory of why the prostate continues to grow as men get older.
Just for listeners who perhaps are not as familiar, the prostate continues to enlarge, and sometimes it can just be a benign enlargement, what we call benign prostatic hypertrophy, versus prostate cancer. And as you mentioned, we're going to focus a bit more on the second aspect and prostate cancer. And sometimes people ask me as a GP, can they come in and get a PSA, a prostate test to screen for this sort of cancer? It's not a regular part of the NHS screening program at the moment. And I just wonder, is that different in the US?
Yes and no. Two things. One is benign prostate enlargement is not that benign. Many men really suffer. Sometimes men may not be forthcoming about how much difficulties their prostate is causing them. And so sometimes men kind of put up with it more quietly, but the difficulty emptying the bladder, and that may impact how far people drive on the highway because they need access to a bathroom. And so it may cause social isolation. The men may not talk about that. And so it's not that benign. It also very much disturbs men's sleep at nighttime. And so many adults, as we get older, our sleep is not as good. And so falling back asleep can be an issue. And then it can cause also more bladder infections and infections into the blood. And so the benign is a bit of a misnomer, but it's benign relative to cancer.
It should probably be called troublesome.
Yes. Your question about the prostate screening for cancer is a great question. It's a controversial question. The thinking in the US has evolved over the years and the decades. But in approximately 2012, the United States Preventative Task Force, which is a major recommending organization around screening for diseases, gave it a grade D. There's an A, B, C, D grading, and the grade D essentially means, for the most part, don't do it. However, in 2018, it changed their opinion and it moved it to a grade C, which is have a conversation with your patient and make an individualized approach. And that came in response to an observation between 2012 and 2018 that there were less low-grade prostate cancer was diagnosed, which makes sense because people weren't checking PSA. But during that time period, there were an increase in diagnosis of metastatic prostate cancer, aggressive prostate cancer, approximately 5% per year between 2012 and 2018. Now, was that a cause of the PSA testing change? We're not sure. It's a temporal association. But because of that, in 2018, there was a change.
So the current recommendation from the United States Preventative Task Force is that men between the ages of 55 and 69 should kind of have an individual conversation with their primary care provider about the benefits and the harms of screening for prostate cancer. And that's what we cite in the book. It's within the context of this history and each individual's personal values and ideals, and that individual conversation that they have.
And that would apply to the average man at risk. For men with more risk factors, we can start at 45 and sometimes even at age 40 for people who may have the BRCA1 or the BRCA1 and the BRCA2, which people are familiar with, a strong association with breast cancer, but it's also associated with prostate cancer. And so I have a few people in my practice who we started at age 40.
Right. Okay. And we'll definitely come on to the risk factors in a minute. I guess just going back to the screening, because we know a lot of men don't engage as much perhaps with screening or seeing their practitioners as women do. What would be the downsides of screening? Why the hesitation to screen people?
So it depends. I think that the first thing is the person needs to go to their doctor. And so men may not utilize their doctor as much. So that's one. But I do think that the PSA has significant difficulties in that it could potentially miss cancer, and it also has a lot of false positives or false elevations. And so there could be anxiety due to an elevation in the PSA. For example, a recent bladder infection can cause the PSA to be elevated. Sometimes even ejaculation within 48 hours of a PSA test. And so if a patient does not know they're getting the blood test and they have sexual activity, then that can cause some false elevation. And so that may lead to some anxiety. That certainly will lead to repeat PSAs. It may lead to some ultrasounds of the prostate. It may eventually lead to a biopsy, and it may lead at some point to having surgery. And so all of these have risks associated with them. The prostate gland is not an easy gland to access from a biopsy perspective. And because that pelvic area is so tight with nerves and other important functions, any kind of intervention can have collateral side effects. And so there are risks. We also know that when doctors study men who died of natural causes and look at their prostate, there's a lot of low-grade prostate cancer. Probably more than 50% of men in their 80s, when they do autopsy studies, they see low-grade prostate cancer. And so it's not clear, there is ambiguity to what extent the PSA testing will actually increase longevity, which is what we really care about. And so that's part of the controversy. And there's certainly side effects to doing the biopsy. There's prostate infections and certainly side effects from having the prostate gland removed.
Certainly for the purposes of people who have symptoms and they come to see their doctors, it's quite clear they will be examined and more than likely have a PSA test if their symptoms are needing that. But I guess for people, men who don't have any symptoms at all, who are just worried because they've heard about something. For example, in the UK, I'll give you an example of why I mentioned this. We have a very well-decorated Olympian, Chris Hoy, who recently was diagnosed with metastatic prostate cancer at a very young age, at 48, and made a public announcement about it, about the diagnosis. And I guess my question is, are there more aggressive, you mentioned this sort of metastatic, aggressive form of prostate cancer that we need to worry about or that we need to be thinking about in terms of screening men who don't have any symptoms at all?
When looking at like some of the trends in the United States, specifically by the American Cancer Society, we've seen in the past 10 years that the incidence rate of prostate cancer has increased by about 3% every year. But specifically, the incidence rate of advanced prostate cancers has been increasing at about 5% every year. So unfortunately, we are kind of seeing this uptrend in the overall number of people diagnosed with this cancer, and specifically the people diagnosed with this more aggressive, advanced cancer in the United States, at least.
We are seeing more rise of invasive cancers in younger people. This is also common in colon cancer, unfortunately. However, it's not clear that screening strategies will identify those cases, because for this individual who was 48 and has metastatic prostate cancer, it may have started 2 or 3 years earlier, or a screening program that starts at age 50 perhaps may not have identified that. And we know that as a society, we do have limited resources. They're not infinite. And so it's a question certainly beyond my skill set of how a society should best utilize the resources to maximize the health of their society. It's a broad and complex question.
Yeah, absolutely. I think it's raised a lot of anxiety as well, as you say, in men who are actually very well and have no problems with their prostate at all, which is obviously a concern.
Getting back to, just we're so passionate about this, is that getting back to why prevention is so important and why, rather than let's screen for the disease, let's create a society that has less cancer.
I was just going to pick up on, the idea that prostate cancer and colon cancer, that there are cases happening earlier and we're not always exactly sure why that is. But with prostate cancer, some of it is certainly down to genes, isn't it? Or perhaps ethnic variation. Certainly in the UK, we actually have, a campaign that runs constantly to try and raise awareness in Black men. And they're advised to have a PSA test at the age of 45. So what do we know about ethnic differences, for example?
We know a lot about ethnic differences. We also know a lot about genetic differences. When we kind of talk about how someone's risk for a disease can be attributed to their genes or their ethnicity, in other words, like how much a disease is heritable, the gold standard that we use currently for understanding this is twin studies. Twin studies kind of give a unique perspective for observing the difference in the role of nature, which is genetics, versus nurture, which is more environment, in determining what the root cause of a disease might be. The idea of these kind of studies is that if a disease is heritable, it's more likely that either both twins will get the disease or both twins will not. And on the flip side, if the disease is not as heavily based in genes, in some cases, one twin could get the disease and one won't. One limitation of these studies is that they often underestimate the influence of environment in disease development because, like, often twins will grow up together. They tend to live similar lifestyles. They tend to grow up in similar environments. So definitely underestimates the role of environment. But in regards to prostate cancer, we actually specifically talked about 2 large-scale twin studies in the book on this topic. And I'll just briefly mention one of them, which looked at nearly 100,000 twin individuals. And they found that genes do play a statistically significant role in men's risk for prostate cancer. Specifically, they found that about 42% of their study's participants' prostate cancer risk could be attributed to their genes. So about 42% of their risk for prostate cancer could be due to genetics. And this is significant. This isn't a small amount, but that also statistically implies that nearly 60% of their risk was not related to their genes, suggesting that even environment could be the primary contributor to their prostate cancer risk. I feel like this is kind of an empowering statistic because it kind of says even if your father or your grandfather had prostate cancer, your fate isn't necessarily sealed, because potentially more than half of your risk for this disease actually falls outside of your genes and instead into your environment.
Yeah, absolutely. And I think there we're getting onto the crux of the usefulness of the book, aren't we? Because we're getting into that area that we call the modifiable risk factors. So we're moving on to how the book is explaining how you can reduce your risk of getting prostate cancer. On this podcast, we talk a lot about different lifestyle factors, but one of our main focuses is talking about how we eat. So can we start there? Can you tell us about the importance of diet with respect to controlling your risk of getting prostate cancer?
I mean, it's everything, right? Health starts in the kitchen. That's something Dr. Gavi and I say frequently. And we believe that diet and lifestyle in general can be essential players in men's risk for prostate cancer. In the American Cancer Society's latest guidelines on cancer prevention, they say that the most variation in cancer risk across populations and then amongst individuals in those populations is actually due to factors that aren't inherited. Like you mentioned, these modifiable lifestyle risk factors. The majority of the causes of differences in prostate cancer risk and incidence between people, according to the American Cancer Society, is not unchangeable factors like our genes. They're instead the choices that we make every day in our lives, like diet.
Yes, I agree. And sometimes people are surprised when I talk to them about the importance of diet. They say, can food really have that much of an impact? I said, well, let's think about it. We're putting all these chemicals into our body. Why wouldn't they have a strong impact? And also we know that our bodies are old evolutionary, and we've evolved with certain ecosystems, with certain foods in our environment. And probably plants are the food source that has been there for the longest time in terms of what humans ate 10,000 years ago. And as a result of that, our bodies have adapted to use these chemicals in the foods to promote our health. Yeah, food has a really big impact.
Okay, so my next question is, I've obviously read sort of how you came to write the book, but what I wanted to know was, were you aware before you started what was going to be the likely direction of the research that was going to go into the book, i.e. that it was going to emphasize this power of diet and lifestyle in preventing prostate cancer? Because I want to come back to the fact that you mentioned a 2007 study which demonstrated the power of vegetables, specifically cruciferous vegetables. Yeah, there's 2 parts to the question. What was your awareness before you started? But also, where there's this study dating back 17 years old now, why do you think it takes so long for there to be such traction in diet as an idea for prostate cancer?
In terms of background for the book, it began for me when I stumbled across a book that I was reading, but it talked about choline, which is a protein in egg yolks, and how that can potentially promote prostate cancer. And I said, boy, I went to a really great medical school. I went to a great residency. I've been a doctor for over 10 years. I've never heard of that. And then I came across lycopenes in tomatoes and their potential role in reducing the risk of prostate cancer. And I said, boy, I've never heard of that either. And boy, there's a lot that's missing in my education. And so I started reading more about nutrition. I said, boy, there's a lot of power here. And recognizing that a lot of my training was really more about physiology, how the body works, pathophysiology, how things break down, and disease treatment. And that really this wasn't part of my education. So I didn't know what we were going to find. I knew we were going to find some information. And then Maya and I came together and we started doing research and found the various studies that we did. We looked at a lot of studies and then we organized them into chapters. But for me, it was a big surprise and a wake-up call to see the impact of the food choices, how much studies have been done, and it's not part of traditional medical education, partly because there's so much to learn, and a lot of medical education takes place in hospitals around sick people. And so sometimes this information is not part of the curriculum.
Yeah, and how you were speaking, how it's such a slow process to go from the research to like common practice. It took that long for Dr. Gavi and I to learn about this, and we're both in healthcare. Like, how much longer is it going to take to get to the general public? And that was kind of our goal with this book, was like, there's such a wealth of data out there. And we both are strong believers that people have more conviction in their decisions if they're educated and if they're informed decisions. So we wanted to take, like, kind of break down that barrier, get that medical research that has been conducted for decades and is so extensive, and make it accessible to any person who might want to read it. There is such a delay in, when things are published and when they become common practice.
In your book, and what we try and do with this podcast is we have a lot of health professionals listening, and we hope that they're able to sort of take on some of these messages and pass them on to patients. The question is what foods should we actually be highlighting to patients, and what sort of evidence is there for those particular foods?
The crux of the issue. So you were mentioning cruciferous vegetables in general, but specifically cruciferous vegetables. And for like a quick definition for listeners, those are like a nutrient dense family of vegetables that includes broccoli, cauliflower, Brussels sprouts, cabbage, collard greens, kale, bok choy, daikon, and watercress, amongst other vegetables. This specific family of vegetables, but vegetables in general, are packed with micronutrients that are essential for our bodies. But even more than that, they kind of contain these anti-cancer warriors, which are called phytochemicals. Phytochemicals are chemicals that our bodies cannot make for themselves, so we have to get them in our diet. And vegetables, and specifically cruciferous vegetables, are packed with phytochemicals. And these nutrients are one way that we can kind of explain why cruciferous vegetables can play such an important role in helping our bodies fight cancer. Similarly to cruciferous vegetables, like Dr. Gavi was mentioning, tomatoes are also kind of a superfood when it comes to fighting prostate cancer, in part because of their high content of lycopene, which is another type of phytochemical. They also have a very nutrient-dense profile in addition to that one phytochemical. But both of these families, cruciferous vegetables and tomatoes, are great for you, and they're pretty easy to incorporate into your diet in so many forms.
And if we're really struggling to get a patient to take on this idea about eating more fruit and vegetables, and particularly the ones you mentioned, can they take a supplement instead?
That's a good question. Our research found that the supplements with these phytochemicals, for example, lycopene, or what we find in cruciferous vegetables, they're just not as effective. That one specific chemical, that one specific nutrient, is part of a larger symphony of packed, chock full micronutrients that come in these vegetables. And we just find time and time again, study and study again, that focusing on the whole plant is really the most effective way to get all the health benefits.
Yeah, absolutely. I mean, we always find it incredible how we know, for example, that people don't eat enough fiber. And I've seen people on Instagram taking scoops of fiber and putting it into their sort of protein shake and things like that. So there's always people who want to cut corners on these things. But what I want to talk to you about now is a bean that me and Daisy in particular, we really love, which is the soya bean. And It's the one where I still meet patients. If I mention eating soya, male patients, they get a bit nervous. They're not sure that I'm getting my information right. So can you clarify for listeners, what is the information that we know to be the right information about the links between eating soya and the health of the prostate?
So we can talk a little bit about why people have concerns about soy and cancer, particularly soy and breast cancer. This has been a concern that I've heard. One of the reasons is that the molecular structure of soy has some similarities to the molecular structure of estrogen. So people can be concerned that soy may function like estrogen, but there have been studies on soy consumption in women who have breast cancer, so the highest possible risk group that you could imagine. And these people who consume soy do as well as people who don't consume soy, and sometimes even better. So what we can learn from these studies is that soy consumption in women who have breast cancer or who have recovered from breast cancer doesn't cause more issues. And considering that this is possibly the highest risk group, I think that can kind of like reassure people that have like concerns about like the estrogenic effects of soy, that it's really not much of an issue. Regarding prostate cancer, I think the answer to your question is probably at the heart of our book, that we wanted the data to lead people to their own conclusions. So we present the data as it is. And the data shows that people who eat soy as a component of a diverse, healthy diet do have healthier outcomes. They live longer, they have less prostate cancer. That said, the data also supports that we should avoid these high concentration supplements. Like you were talking about, like fiber supplements, just scoops of fiber. That's kind of where we see some issues when it comes to soy, is like these concentrated supplements, because they're not as effective as focusing on the whole product, like the edamame bean as it comes, which can be like a healthier and more protective way of eating soy.
So I've got so far cruciferous vegetables, tomatoes, and we've talked about soya in general for reducing rates of cancer. Are there any other particular foods or food groups that we should mention before we move on?
One of my favorites is green tea. I like tea, and I like green tea. And I like green tea that's flavored. So I have like pomegranate green tea and a few other flavored green teas. And they're really fun. As someone who tries to implement this knowledge in practice, I think two themes come to mind: pleasure and easy. And I think green tea is pleasurable and easy. And I think this gets also into this idea of how do we operationalize the knowledge? Because probably knowledge is not enough. People need help. There's too many hard things to do in life. Getting the kids to school, paying bills, whatever. So we really don't want to add too many hard things for people to do. We want to make it easy, and we want to add pleasure. And I think green tea is one of those really easy, really pleasureful health habits. It may even be healthier than drinking water. I would say it's also interesting how our sense of taste evolves over time. And so over time, I am more enjoying green tea that's not flavored. And initially, I didn't like it. And I thought I would really not like it. And it's really interesting how we don't give ourselves enough credit for how our sense of taste and our sense of life can adapt.
I totally agree with that, because I had the same issue. Can we just go back to soya, Claire? Because we always talk about soya, and I thought I hated tofu, but I love tofu. I just didn't know how to cook it properly. Would you give us a couple of examples of how you both use soya in your day-to-day life?
I'm a huge fan of the air fryer, and I take tofu and I put it in the air fryer with a little bit of spray olive oil, and it gives it a really crunchy texture. And then my kids enjoy kind of as finger food, then they'll dip it in dipping sauces and eat that. And what's nice about that is then I'll take that and also add it to like the stir fry. So, in many families, you can't cook 6 dinners, because I like vegetable stir fry a lot. So I'll take that tofu and add it to the vegetable stir fry. But then also the kids who don't like the vegetables stir fry, I'll give them just the tofu and they can play it by hand. And so I'm a huge fan of that in the air fryer.
One of my favorite dinners is tofu spring rolls. They're so easy to make. I just use some rice paper wrap rolls and oven baked tofu, some carrots, some cucumbers, some green onions, and just wrap it up. And I feel like it's so delicious with any sauce of your choosing.
Oh, brilliant. We'll ask you about your dinner later, Maya, but it's good to hear you put tofu in a spring roll.
Yeah.
I feel like I'm going to bring things in the other direction now, because we usually don't like to talk too much about having to cut things out of the diet, give things up when we're trying to motivate patients to make sort of lifestyle changes. But I think with the prostate cancer issue, we kind of have to go there, don't we? So can we talk a little bit about what foods we might advise patients to avoid?
Yeah. I think it's really important to discuss red and processed meats when it comes to foods to avoid. In 2015, the International Agency for Research on Cancer, a division of the World Health Organization, actually independently classified red and processed meats as carcinogens, basically independent predictors of prostate cancer. So just let that message sink in, because that means that there's enough data in the world to make a statement that red and processed meats independently and directly contribute to and predict men's risk for prostate cancer. In the book, we reference a few studies that show that as a country's consumption of red and processed meats increase, you actually see a proportional linear increase in their rates of prostate cancer. We also talk a little bit about dairy. We found that there is a significant difference in the risk for prostate cancer and the consumption of low-fat versus whole-fat dairy products. We saw that in these studies that as men's consumption of higher-fat dairy products increased, their risk for prostate cancer increased also in a linear association. Furthermore, the whole milk and whole fat dairy products were associated not only with increased risks for prostate cancer in general, but specifically increased rates of lethal advanced forms of prostate cancer. So as you go down towards the lower fat dairy options, some studies showed that while there is still some connections, some studies showed that there was no connections. That's always, we like to stick to the data. And based on what we saw, these researchers were recommending basically leaning towards the low-fat dairy options, or even shifting to dairy alternatives. We've talked about soy. I really love soy milk. Almond milk is also a great option, and that's something we talk about in the book as well.
Anything about eggs?
I'll let Maya speak a little bit as well, but I'll just say eggs are controversial, but they do have the choline protein, which has been suggested to be a risk factor for prostate cancer.
Yeah, I think that's at the heart of it. We included a few studies in the book about why eggs might not be as healthy for us as we previously thought they were, specifically eggs in excess. And like Dr. Gavi was saying, researchers kind of pointed to choline, a nutrient that's very rich in eggs, as a potential source of this danger for prostate health when in excess. In this chapter on foods to avoid, in this thought of foods to avoid, we need to consider these things in the context of excess, especially, and finding moderation in our lives is so important. So just for eggs, like with meat and dairy products, we would encourage people to cut down on these foods as part of a shift towards that healthier lifestyle. You can also consider these foods in terms of a cost benefit analysis, right? If you're eating eggs, what are you eating them instead of, right? Could you be having avocado toast with a slice of tomato on top of it instead? So I think that's also an important consideration.
Certainly when we were putting the episode together, we were looking at what some of the bigger organizations that are standing on cancer research are saying about something like dairy. The World Cancer Research Fund seemed to say, definitely high quantities of dairy can increase your risk of getting prostate cancer. But then when we looked at one of the UK cancer research organisations, Cancer Research UK, it said, no, not a link with dairy. So is there a lag between guidance and what patients are being told and what the evidence is saying?
Well, I guess I would respond in a few things. One is food studies are hard to do because people who don't eat dairy may do other things that dairy eaters eat. So food studies are hard to do. There's confoundings. People who eat more red meat probably have other lifestyle factors that track along with that. Food studies are hard to fund. There may not be a strong pharmaceutical interest. And so they're hard to do. And so sometimes the results aren't that consistent. There's some inconsistency in the results. Maybe we're being a little too granular. We kind of need to step back. We know that when it comes to eating a broccoli and an egg, there's no comparison. You know, tomatoes are way healthier than an egg would ever be. And so I also think that some organizations are more cautious than others. And obviously in the US, there's a big dairy interest groups and it affects finances. And so recommendations around food have really broad societal, political, economic consequences. And I think some groups are going to be more cautious around that. But I think if we take a step back, we do see that on the whole, a diet that is more plant-based, whole plant-based, and a lifestyle that involves movement is going to be healthier. And without getting too caught up, is it 2 eggs a week or 1 egg a week, or is it, can you have a little bit of low fat? On the whole, if you step back and you look at this book and you look at the data on food and cancers in general, there's a very consistent story. Not only that, if you take a look at our choice of foods and health outcomes in general, and you take a step back, there's a very consistent story. One of the main messages of our book is this, what Maya refers to as sort of this double dipping. Not only will exercise be better for reducing prostate cancer, but it's also going to be good for your heart and prevent strokes and reduce stomach cancer and other issues. And so I think there is a very pretty consistent large message, if we take a step back, that the kind of lifestyle that supports prostate cancer is going to support many aspects of people's health.
Brilliant. I think that's really clearly put, isn't it? That's exactly the sort of message that we're giving out in this podcast as well, is that quite a lot of these preventable illnesses have the same sort of risk factors. And you mentioned exercise, which segues on beautifully to our next question, because both Claire and I love to exercise. We both run and cycle and hike and things like that. So can you tell us a bit more about exercise and the benefits that can have for prostate cancer? Is it just about weight reduction, or is there more to it than that?
In our research, we found several studies that not only linked weight with increased risk for cancer, so higher weights with increased risk for cancer, but also linked higher weights with cancer-related death. So prostate cancer was one of the most prominent cancers to be found to be linked with weight, but several other cancers, esophageal, colon, rectal, liver, gallbladder, the list goes on, they were also found to be linked with weight. Other leading causes of death, like Dr. Gavi was mentioning, this double dipping, other leading causes of death in the US and worldwide are also correlated with weight, including heart disease and stroke. The American Cancer Society looked at the association between prostate cancer and weight in a 7,000 person study and basically found 2 important findings that are worth mentioning. The first is that higher weight is significantly associated with increasing men's risk for getting high-grade and fatal prostate cancers. And then the second thing that they found was that participants in their study who lost 11 pounds or more during the first half of their study were significantly able to decrease their risk for advanced prostate cancer, they found by up to 42%, which is huge. These findings kind of support that weight does play a role in increasing men's risk for aggressive and fatal forms of prostate cancer and reinforce the theory that weight loss can be an effective way of reducing this weight-related cancer risk. There's quite a few theories for why obesity and being overweight increases men's risk for prostate cancer and prostate-related death. One of the leading theories is that obesity and specifically abdominal adiposity leads to changes in the body that increase prostate cancer progression from early stages to later lethal stages. So some researchers basically believe that obesity does not necessarily increase the initial risk for getting prostate cancer, but rather decreases the chances of surviving a prostate cancer diagnosis. Some of these changes to hormone levels, increased insulin resistance, hyperinsulinemia. These have all been found to be involved in prostate cancer progression.
Interesting, because I was just going to ask you that exact question. How much of these lifestyle interventions would be just as beneficial to men already diagnosed with prostate cancer? Because I know we've talked a lot about prevention, but if somebody already has a diagnosis, what would you say to them?
We do have some studies in the book that actually these lifestyle interventions can slow down the progression of prostate cancer. That is established. It's also established for other cancers as well. And so the preponderance of evidence suggests that after a cancer diagnosis for prostate cancer and other cancers, lifestyle factors have been shown to reduce progression and reduce the risk of relapse.
You've convinced us that there are some really easy things men can do to prevent their to reduce their chances of getting prostate cancer. But we wanted to ask you a little bit about how we could encourage more men to be proactive when it comes to their health, because certainly I think it's a thing common to the UK and to the US that women tend to be more receptive to these kind of preventative health messages than men. So what are your views on how we might help men with taking up some of these ideas?
I guess one of my views is a few views on it, because I work a lot with men and I've been in practice for 25 plus years. But I think we need to make it easier for people, and we need to maintain pleasure. And I also think that part of this rests on the societies that we live in and the ecosystem that men and women find themselves in. Societies where people are not working 80-hour weeks, where they have time to walk, where they have time to cook, and they have the mental bandwidth to think about where's my food coming from, and also to be a society where people are rested and reflecting on, well, why am I even eating this right now? Am I even hungry? Stress levels, people's nervous system. And so I know that that's a lot to talk about, but the knowledge is not enough. We need to help people implement the knowledge. And part of that is creating societies and ecosystems where people will be pulled along, not that they need to push against a certain current where it makes it much harder. And I think we place a lot on individuals to make these changes. And I think that if people were able to make these changes, they would. I think it's just hard. And so I think part of operationalizing it is beginning to think about our lifestyles that we've adopted for ourselves, and then the ecosystems that we find ourselves in.
Yeah, I completely agree with you. It's we put a lot on individuals when it comes to things like food, and there are so many things that need to change in the environment to sort those things out. Do you think there's any merit in running any campaigns that highlight the symptoms of prostate cancer? In particular, we haven't talked about it, but we talked actually before we came online about how erectile dysfunction can be a symptom of prostate cancer. Is there any merit in honing in on a symptom like that men are particularly sensitive to raise their awareness of these issues?
There isn't a right answer. There's merit to a lot of things. I would say that as a practicing doctor working with men, I like to tap in, what do men like to do? And how do I help them do more of that? And so, I have men who, love to ride motorcycles, across the country. I said, well, if you want to do that, we've got to take care of your health so you can sit on the motorbike without back pain. And we need to do core exercise, and you need to lose weight so that you can do more of what you love. Telling men, in my experience, if you do this, you reduce your chance of cancer in 20 years. There's kind of like the certainty of pleasure today and the potential, who knows, benefit in 20 years. And so people are kind of going to say, well, I know this will bring me happiness today. And so I think we need to keep it positive, tap into their joy and their passions. And I think that will give them the energy and the excitement to do these changes.
Yeah, that's absolutely a good point. Those are key coaching skills, I think. Daisy and I are right in the middle of our lifestyle medicine diploma, aren't we? So we're all about finding what motivates people. I'm going to ask a more difficult question now, or at least, that was hard enough, but I think we need to go back and think about when you were doing the research for this, and you obviously went through so many studies, so much medical literature, and I wondered whether there were any apparent gaps in the knowledge. Did it sort of give you any ideas about where research needs to focus next, or do we already know enough? We just need to find ways for society to make these things easier to do.
When Dr. Gavi and I initially started our work together, we were actually only going to write an article about prostate cancer prevention. That was our first goal. We didn't even think about writing a book until we saw just how much research, like the incredible wealth of research that exists. And we were pretty overwhelmed by it, and we didn't know about it. And again, we're in healthcare. We didn't know about all of this. So if we two people in healthcare could find all of this information that we had no idea about, supporting lifestyle changes in helping prevent prostate cancer and helping prevent other cancers and helping prevent leading causes of death in the United States, how could we expect other people to know about it? And so, of course, there's always room to expand the knowledge base, but perhaps the real value now would be in disseminating the impressive amount of peer-reviewed literature that already exists and finding ways, like Dr. Gavi was talking about, of implementing these findings into our lives to improve our health, finding ways that motivate people to make these changes that are so strongly evidence-based.
Right. I think we're back to we need a system that values lifestyle medicine doctors a bit more, but perhaps that's another episode. So we've talked about everything that we wanted to cover. Is there anything that you want to add at this point that you think would be helpful for listeners?
I guess I'd like to express my gratitude to the two of you, Daisy and Claire, for making this a part of your work life and passion. I think these are conversations that are ongoing. I think that all individuals in society and our patients, I think, benefit by having conversations, because we want to respect their value system, their autonomy. And so I really want to just express my gratitude for initiating and maintaining these conversations. They're really important, and they benefit all of us.
Oh, thank you so much for that. One of the things that we really love to come back to at this point is, you may not do this in consultations with patients, but we find that we love to motivate people by talking about food. And so we ask all our guests, can you tell us what you're having for dinner tonight? So I don't know who wants to start. Maya?
Absolutely, yeah.
Oh, yeah.
One of my go-to dinners, I'm a busy medical student, so I have to have things that are quick and pretty efficient. One of my go-to dinners always has a side of a Middle Eastern salad. So just diced cucumbers, diced tomatoes, diced onions, little olive oil, little lemon juice, salt and pepper. And that's my favorite thing to add to every dinner. It's super easy and quick. And I'll be having that tonight.
That sounds great. When you're working as a doctor, it's amazing how you can really connect with a patient by talking to them about food. And this is a section where we really hope that we connect with our listeners as well. Can you tell us, Dr. Gavi, what your recipe tip for what you're having for tonight's dinner is that's going to hopefully reduce people's chances of getting prostate cancer, or any other cancer for that matter?
Well, tonight we're going out to dinner because one of my kids has a program, but this restaurant has this great kale chickpea salad with this wonderful dressing that's really very tasty, very flavorful. And I feel really good after eating a salad like that. I feel not only is it healthy for me, I enjoy it, it's good for the planet. One of the nice things about this book is that when you do things that are good for you, it kind of brings you more pleasure. Not only do you enjoy the food, but you're kind of more aware of the impact of your eating, both as an individual and more broadly.
Great. I'm going to just go straight over to Daisy, who's usually got a good suggestion as well.
Well, I can't remember if I've already said this on the podcast, so excuse me, listeners, if you've already heard about it, but I love it so much.
We need to get the tally sheet in, don't we? This is what we were talking about. We need to keep track of our meals, but anyway.
Anyway, it is sticking to the tofu theme, because I do love tofu, and very similar to what you mentioned, Dr. Gavi, I've got an air fryer as well. So I'll put some tofu, I'll sort of break it up or cut it into chunks, and coat it a little bit with corn flour, because that gives it a very crispy edge, and then pop it in the air fryer. And then I can add that to any sort of, usually it's actually an oriental based sauce, like a sweet chili or a teriyaki type sauce. And you can knock that up quite quickly, or buy a ready-made one if you haven't got the time. And often I'll have that with brown rice and some steamed vegetables on the side. So it's a go-to, Clara. I just do it, regularly. I'm sorry if you've heard it already. What about you?
I don't think we can hear enough about your air fryer. I'm always saying this. So no, absolutely don't mind at all. Well, as Dr. Gavi was talking about his meal, I was thinking, gosh, that sounds almost like I could take that and blend it up and turn it into the soup that I'm planning on having, because it's got all the same ingredients. It's kale, it's chickpea. I might add some peas in there as well, just some frozen peas, but some silken tofu. And like it's a hot version of a salad, I'll add some garlic and a few spices in there as well. But you see where I'm going with that. It's almost like the same ingredients, but just served hot. I don't know, maybe there's a difference in weather between London.
Well, I was going to say, that shows who's in California and who's in the UK.
Yeah, no, I definitely need a hot soup tonight and some sourdough bread with that.
So what are you going to do? Just blend it all together, cook it up and blend it? Or do you have the chickpeas, because some people do chickpeas as like a crouton, don't they? Like a crispy topping.
Do you know what? Now you've said that, I might go half and half. So I might put half in the soup and then just put some on the tray with, just some spices and just crisp them up as some croutons. Yeah. It's a great idea as ever, Daisy.
That's nice. A bit of texture.
Yeah.
Lovely. Oh, sounds great. Well, we won't keep you any longer. We know you've got busy days ahead in the States today, and it's evening here, so we're getting ready for our
working day.
Yeah, exactly. But we know you've got time constraints. So we'd like to say thank you very, very much to both of you for your time and your expertise today. And we will definitely be linking the book in our show notes. So if listeners, please get yourself a copy and have a read. This is such important information. But if our listeners do want to connect with you or have any further questions, where can they find you?
We'd be happy to provide our emails through whatever you link as well, and people can reach out to us directly.
Great. And any social media accounts, or are you both off?
We try to be off it.
Fair enough. Okay.
Thank you both for having us.
Thank you so much.
Bye-bye.